Good morning or good afternoon to everyone. My name is Ralph Brindis. I'm the chair of the California Technology Assessment Forum, better known as CTAF. Today, we're having a meeting to discuss a novel new therapy, brensocatib, for the treatment of non-cystic fibrosis, bronchiectasis, assessing its effectiveness and value. At the beginning of every CTAF meeting, we want to ensure that all our speakers disclose any financial relationships with industry. Every member of our CTAF panel who's present today has met the ICER conflict of interest policy. We're now going to introduce our CTAF members, their work, and note whether there is any change in their updates to this declaration. Dr. Felicia Cohn.
Good morning. I am the Bioethics Director for Kaiser Permanente in Orange County and a clinical professor in the School of Medicine at the University of California, Irvine. There are no changes in my conflict of interest.
Thanks, Felicia. Robert Collier.
Hi, I'm Bob Collier. I'm a 30-year plus patient advocate concentrating on medical research for the whole damn time. This particular time, I just want to point out, as focused on the agenda, my wife has received funding from AstraZeneca last year for an early breast cancer research registry. That's it.
Thanks, Bob. Dr. Paul Heidenreich.
Paul Heidenreich. I'm a cardiologist and health services researcher at Stanford University.
No updates.
No updates.
Thanks, Paul. Dr. Jeffrey Hotch.
Good morning. Hi, my name is Jeffrey Hotch. I'm a professor of health economics and chief of the Division of Health Policy and Management at the University of California at Davis. I have no changes to report.
Dr. Jeff Klingman.
Hello, I'm Dr. Klingman. I'm a neurologist currently working part-time at the Permanente Medical Group. No conflicts.
Dr. Sei Lee.
Hello, my name is Sei Lee. I'm a professor of medicine in the Division of Geriatrics at the University of California, San Francisco. No updates to the conflicts.
Dr. Kavita Nair.
Hello, I'm a professor of neurology and pharmacy and outcomes researcher at the University of Colorado, Anschutz Medical Campus, and I have no conflicts, no change in my conflicts.
Dr. Catherine Phillips.
Yes, good morning. Catherine Phillips, Professor of Health Economics, UCSF, no updates.
Dr. Rita Redberg.
Hi, I'm Rita Redberg. I'm a cardiologist and health services researcher at the University of California, San Francisco. No conflicts and no updates.
Tony Sowery.
Good morning. I represent the National Patient Advocacy Foundation, and I have no updates or conflicts.
Thanks, Tony. And again, I'm Ralph Brindis. I'm a clinical professor at UCSF, a cardiologist by training, and I have no updates to disclose. Next slide, please. At this time, I would like to ask our patient experts to reveal or discuss any of conflicts of interest that they have. Amy Laitman.
Hi, yes, Amy Leitman, President of NTM Info and Research. I have nothing to update with my conflicts.
Thanks, Amy. John Torrance.
Hi, John Torrance. I'm a bronchiectasis patient, and I work as the patient ambassador for the Bronchiectasis and NTM Association, and I have no conflicts.
Thanks, John. Next slide. All right, and now we'll turn to our clinical experts. Dr. Timothy Axamit. Are you on mute?
Sorry about that. Again, hello, everyone. Don't have anything else to add. I'm a professor of medicine, pulmonary diseases, critical care at Mayo Clinic in Rochester, Minnesota. Thank you.
Thanks for being here, Tim. Dr. Paul Diefenbach.
Hi, good morning and afternoon. Thanks for having me. My only other declaration is I also am a senior physician editor at Up to Date for Wolters Kluwer.
Thanks for being here, Paul. And I'd like to also request any speakers participating in the policy roundtable or individuals making public comments, they should also announce at that time any financial relationships with industry or other potential influences on any judgment when they speak. At this time, it's my pleasure to introduce Sarah Emmon, President and CEO of ICER. Sarah?
Thank you, Dr. Brindis. It's a real pleasure to be with everyone today, and we appreciate everyone attending this public meeting to talk about a new therapy for non-cystic fibrosis bronchiectasis. You'll hear from several colleagues today. Jason Wasfy served as the evidence author for this report, and he is an associate professor at Harvard Medical School. Dan Ohlendorf served as the senior management lead for this review. He's our chief scientific officer and director of HTA methods and engagement. And Ki-Boom Kim was the lead modeler, developed the economic model for us with his team. He's an associate professor at the University of Illinois, Chicago. We'll be hearing from Ki-Boom later. Next slide, please. Whenever we start a public meeting, we want to remind everybody why we're here. There is a sense of celebration, perhaps, because for the first time, there is an approved therapy for this condition. And why was there interest in developing a therapy for this condition? Because of the experience of patients. And so this quote really stood out to us when we talked to many patients and heard from many different patients for this review. My life has been impacted profoundly by bronchiectasis. I no longer travel or attend events with crowds of people. Every decision is made with weighing the health risk factors and allowing time to do lung clearance. I never dreamed that this would be my life in my golden years, instead of traveling and spending time with friends and family who don't live nearby. It feels like I can't get any air until I can get some medication into me for some days. I get a brief reprieve for several hours, and I feel almost like human. Otherwise, it's demoralizing to struggle with this condition. We thank all of the patients who participated in this review. We heard many stories from patients about their experience with this condition, and that will be the grounding force of our conversation today about this new therapy. Next page. But why are we here today? You might think it's FDA approved. All of the questions have been answered. We can all just move on. But no, we can celebrate the approval of a new therapy for a condition that hasn't had a therapy before, as we have in this case, but we still have real questions that we need to answer as a health system. What are the risks and the benefits of this therapy beyond what was assessed in the clinical trials and understood from an FDA regulatory perspective? How does this treatment fit compared to what we already do for this condition? And we do not shy away from conversations about price and cost to the patients, to the healthcare system, and to the government. And at the end of the day, we create this forum for multiple stakeholders to come together so that we can have conversations about where we go next with the evidence that we have, guided by the principle of ensuring patient access and affordability. But what do we need to be doing now to make sure we have the data to inform those decisions in the future? Next slide. One of the things that many of you have heard from me before, if you've ever attended an ICER meeting, is that we want to make sure that we do two things at the same time, because we think that cognitively we can do that. We can talk about this particular condition and this particular drug while still talking about the impacts that we are all experiencing more broadly in our healthcare system. Consider this me ringing the alarm bell. The rise in healthcare costs as reflected in healthcare premiums is on an unsustainable track. The Gallup and West Health poll that came out recently asks a question. If you needed access to quality healthcare today, would you be able to afford it? 35% of respondents said no. That is an all-time high. We are seeing premium increases in the insurance market at a median of 9%. And we heard from the Business Group on Health, which did that survey, a call to action. Employers will need to act with greater urgency and willingness to be bold as they head into 2026 after a second year of actual healthcare costs sharply outpacing projections due largely to prescription drugs, chronic and complex conditions, and persistent delivery system flaws. And we are staring at a potential calamity in our ACA marketplace. If the subsidies expire that have been allowing people to afford health insurance coverage, we can expect to see two things: a drop in the number of people purchasing health insurance, so a rise in the number of uninsured, and a rise in the cost of the premiums because those left in the system are expected to be charged more because they are seeking health insurance. So again, I'm ringing the alarm bell. We are at a really difficult point in our health insurance system from an affordability perspective, and everybody has a responsibility to be participating in solutions. The good news is if you're all here, you care about solutions. So thank you for being here and participating in this conversation. Next slide, please. One of the things, again, that we'll talk about today is thinking about how we're ensuring affordable access to this new therapy for patients with NCFB. And we will hold in our heads and our hearts how we're making sure that the health system remains affordable for everybody else that is seeking care. Next slide. All right, who are we? Who's CTAF? Just a quick primer for those new. ICER is an independent nonprofit. We do health policy research to inform consequential decisions about price, access, comparative effectiveness, mostly for new drugs. CTAF is a program of ICER. The California Technology Assessment Forum is our independent appraisal committee made up of experts in evidence-based medicine, health economics, and patient and consumer advocacy. They will be the ones driving the conversation and the adjudication of this new evidence on effectiveness and value for this therapy. They'll be taking some votes a little bit later today. Next slide. We like to be as transparent as possible about all of our funding. You can see every organization that has given us money over the last 12 months on our website. The link is available there. We also want to be clear that any money that we receive from manufacturers and health plans supports only our policy summit and related activities. The money that supports our research comes from nonprofit foundations. Next slide. We are almost at the end of an 8.5-month process. So this review started many months ago when we started talking about the research questions that we wanted to answer through this comparative effectiveness review. And we learned about how to ask those research questions by talking to patients, clinical experts, the manufacturer, payers, and other stakeholders who were interested. Our team developed a report going through the evidence synthesis. What do we know about the comparative clinical effectiveness? That was led by Dr. Wasfi. And then the team at the University of Illinois Chicago with Kibum developed the cost effectiveness model to answer questions about fair price for this new therapy. We're deeply grateful for the expert review. You can see them listed here, both from the patient and the clinical side, to make sure that the perspectives of those two ideas are reflected throughout our report. We went through an extensive public comment and revision phase, and the evidence report was posted just a couple of weeks ago that forms the basis of the conversation today. Next slide. You're going to hear about value a lot today. So to ground what we're talking about when we talk about long-term value, we're talking about things that can be measured. And that's in green. How much better the patients feel on a therapy, what kind of side effects they experience. Also, any costs or cost offsets that might result from a new therapy working better for patients. That all gets built into the cost effectiveness model that Kibum will bring us through later. There are also parts of assessing comparative value that might be harder to measure, but are still very important to talk about and for policymakers to have in their heads as they make decisions about price and access. Those are represented in these blue box. Special social and ethical priorities, perhaps a a patient group that's been traditionally underserved by the healthcare system. Benefits beyond health, maybe an impact of a new therapy on a community, on a school system. These things are real and very important as we consider comparative value conversations. We're going to be talking about and voting on some of those other benefits a little later today. Next slide. All right, you've made it through the introduction. Congratulations. Next, we'll be hearing about the clinical evidence. After that, Dr. Kim will walk us through the economic model that was designed to try to answer questions about fair price for this therapy. And we'll hear from the public, how they think we've done, what do they think we've missed, how do they want us to be thinking about the impact of this disease and the impact of this therapy on their disease. After a lunch break, the CTAF will come back and deliberate and vote on key questions of comparative clinical effectiveness and comparative value. After a short break, you'll hear from me again, where I am thrilled to be welcoming our patient experts, our clinical experts, and representatives from the payer community to say, okay, what now? Here's what we know about the evidence. Here's what we know about the value. How does this inform conversations and decisions about access and affordability moving forward? We'll close with some reflections from the CTAF, and we will be wrapped up today by 3 p.m. Pacific time. With that, it's my deep pleasure to introduce ICER's good friend, Jason Wasfy, to talk us through the comparative clinical effectiveness. Thank you, Jason.
Thank you, Sarah. I'm delighted to be here. It's a cloudy, rainy afternoon in Boston, and hope it's a sunny morning in California. I'm an associate professor at Harvard Medical School, and I'm a cardiologist. I'm a clinical cardiologist at the Heart and Vascular Institute and the Mongan Institute at Mass General Brigham. Next slide, please. I am really here, I'm the one talking, but it really takes a team, and I have an incredible partnership from the ICER research team led by Avery McKenna with Sophia Cassim and Belen Harris-Kagewara, who've put a tremendous amount of work and rigor into this very complex report, and I'm grateful for their time. These are our disclosures. Next slide, please. NCFB is a chronic progressive lung disease. Symptoms are very different for different people, but typically cough, production of mucus and sputum, shortness of breath every day are common. It's punctuated by exacerbations, and some of those exacerbations require escalation, including sometimes inpatient care, but not always. It's different than emphysema or COPD because the bronchi, the tubes that bring air into the lung, enlarge rather than collapse. Radiographically, it's similar to cystic fibrosis, but it's a different etiology with different treatment. Namely, unlike CF, this is not a genetic disorder. The true prevalence is unclear, but it probably affects up to potentially 500,000 adults in the United States, and many patients are undiagnosed when they have it. The more CT scans you do, the more bronchiectasis you diagnose. The pathophysiology is characterized by a vicious cycle, or also called a vicious vortex, that has different pathophysiological processes that make each other worse. Chronic bronchial infection, inflammation, impaired mucociliary clearance, and structural lung disease. These processes go in parallel and make each other worse. Next slide, please. The prevalence goes up with age, goes up a lot after age 45. 2/3 of individuals have at least one exacerbation per year. And as is so common in the United States, the cost of the condition to the healthcare system is very high, $14 billion per year, $2 billion for hospitalizations alone, which is 2 to 3 times higher than care for NCFB in other countries. The cause is often unknown, but it can be caused by prior infection or aspiration events, specific autoimmune conditions, or structural disorders of the trachea. If you have it, you have a worse prognosis if you're colonized by Pseudomonas aeruginosi or NTM. If there's more involvement of the lung, more burden of symptoms, a lower FEV1, which is a mechanical measure of lung function, older age, or lower BMI. So lower BMI means worse prognosis. Next slide, please. Current treatment options, there's not really a disease-specific therapy. People do airway clearance with chest wall oscillators, nebulizers, and physical therapy. And I'll just emphasize very strongly, we had so much amazing input from patients, their advocates, their family members. A lot of people share your story forms on the ICER's website. This is so burdensome. It's so hard to live with this condition. They're spending huge amounts of their day. It's complex. It requires equipment. So one of the hopes is to sort of see if that can be reduced. In many cases, when you have NCFB, prolonged inhaled or oral antibiotics are recommended depending on the frequency of exacerbations. Pulmonary rehab is recommended in worst cases, and in very severe cases, surgical resection of the lung or even lung transplant can be considered. Next slide, please. Again, we had such rich and deep input from patients. NCFB really affects daily living. You can imagine if you're doing this for hours a day, you can't work in many jobs. It affects social engagement. People are often coughing. Other people think that they're got a communicable illness. So it really is a very difficult disorder to live with. It's unpredictable. Colonization, typically NTM or Pseudomonas, really changes your daily activities. And it's really difficult to find knowledgeable specialists. And one quote, there's so many good quotes that really illustrate the problem, but this one I wanted to pull out. A patient said, "My hope is to be able to work full-time in a career that I love, and to be able to have more energy and be as active as I want to. My hope is to be able to hike again, to not live in fear of a common cold, and to know that I can plan for a long life. Above all, I hope to live a life as normally as possible. I want to live my life, not just survive it." Next slide, please. The scope of our review are adults and adolescents with NCFB. The interventions are brensocatib plus usual current care, and the comparator is usual care alone. As stated, that can include antibiotics, mucolytics, pulmonary rehabilitation, and airway clearance devices. Important outcomes are the frequency of pulmonary exacerbations and daily symptoms like quality of life daily, in addition to safety and adverse events. Next slide, please. Brensocatib is a small molecule reversible inhibitor of dipeptidyl peptidase 1. So it's an immunosuppressant agent that's taken once per day in an oral tablet. It reduces neutrophil signaling, and just referencing that vicious vortex, the four pathophysiological processes that make each other worse. This affects inflammation, and the idea is that by hitting one of the four processes, you could reduce the vortex. And this was very recently approved by the FDA this past month. Next slide, please. The main evidence overview, there was a phase 2 trial, the Willow trial, but we're focusing on the phase 3 trial, the Aspen trial. It was a 52-week phase 3 multinational double-blind randomized controlled trial. There was randomization of 1-1-1 for adults at least. And some adolescents were included with slightly different inclusion criteria to placebo, 10 milligrams of brensocatib, or 25 milligrams of brensocatib. The primary endpoint was the annualized rate of pulmonary exacerbation. So how many pulmonary exacerbations you have per year. And then there was a hierarchical set of secondary endpoints with a pre-specified selection procedure for whether statistical tests were applied. Time to first exacerbation, percentage of patients remaining exacerbation-free, the change in baseline in FEV1, this mechanical measure that's seen on a pulmonary function test, annualized rates of severe exacerbations, and the change from baseline in the respiratory symptoms domain of the quality of life bronchiectasis questionnaire, which is a patient-reported outcome. Next slide, please. The inclusion criteria were generally adults, although there were 41 adolescents included with slightly different inclusion criteria. They could have one exacerbation in the year prior, whereas adults had to have two. They had to be able to produce sputum because of screening for Pseudomonas. They could not have receiving treatment for NTM. And there were some treatments that were prohibitive, primarily immunosuppressive therapies because of the concern with safety with adding an additional immunosuppressive therapy. You can see mean age around 60, predominantly white, about 2/3 female. a mean bronchiectasis severity index score of 7. And about a third, just under a third, had actually 3 or greater exacerbations in the prior 12-month, the more severe cohort. About a quarter were taking long-term antibiotics per the clinical guidelines articulated before, and more than half were taking inhaled corticosteroids. Next slide, please. In terms of the primary outcome, this was a positive trial. You can see that for the 10 milligram dose, the rate ratio was 0.79. And for the 25 milligram dose, again, both of these are compared to placebo. They're not compared to each other. The rate ratio of 0.81. So treatment with brensocatib reduced annualized exacerbations compared to placebo. Next slide, please. The time to first exacerbation was similarly decreased with a hazard ratio of 0.81 for the 10 milligram dose and 0.83 for the 25 milligram dose. So treatment with brensocatib led to a longer time until the first exacerbation compared with placebo. Next slide, please. In terms of the proportion of individuals that were exacerbation-free over the length of follow-up, this also was different. It was 48.5% of both treatment groups and 40.3% of the placebo group. So you can see roughly an absolute risk difference of about 8% between the placebo and the 2 treatment groups. Next slide, please. In terms of FEV1, again, this is a mechanical, it's not patient-reported, it's a mechanical measure from pulmonary function tests. There was some discordance between the 25 milligram dose and the 10 milligram dose. So for 25 milligram dose, there was a statistically significant difference in the FEV1 change. So to be clear, FEV1 gets worse in all groups, placebo and both treatment groups, but it gets less worse in the 25 milligram dose compared to placebo by 38 cc's. The MCID, this is a little bit complex because there's not a minimally clinically important difference defined for this condition, for this parameter, but when you borrow from other respiratory conditions, a minimally clinically important difference is over 100 cc's. So if you borrow from COPD, acknowledging the uncertainty around whether that's a valid way to do it, this is a very small difference that's under a minimally clinically important difference. Next slide, please. In terms of annualized rate of severe exacerbations, because of the testing procedure, there wasn't a statistical test applied to 10 milligrams, but there was no statistically significant difference between brensocatib 25 milligram and placebo. It was it was numerically lower, but the statistical test was not significant. Next slide, please. In terms of this patient-reported outcome, the quality of life bronchiectasis questionnaire, the minimally important clinical difference for this is 8. So this requires some nuance here, is that the 25 milligram dose relative to baseline just barely exceeded 8. Whether this MCID is properly applied relative to baseline versus the placebo group is unclear. It's been used different ways, but the point here is that the placebo group gets better too. So the difference is not 8 between brensocatib 25 milligrams and placebo. It's brensocatib 25 milligrams is different from its own baseline, not from the placebo group. So overall, I would say, again, there was no statistical test applied because of the hierarchical procedure, but at best, a small difference for the brensocatib 25 milligram dose relative to placebo. Next slide, please. In terms of subgroup analyses and heterogeneity of treatment effects, there wasn't statistical power for these key subgroups, although if you look at the forest plot, for people who are more severe, FEV1 less than 50% or a BSI greater than 9, the midpoint of the range is sort of near unity. So it's not, there's no clear difference in the treatment versus placebo in those subgroups. In addition, people with asthma some of whom were allowed into the trial, there wasn't a clear statistically significant difference in that subgroup, acknowledging that it wasn't powered to detect such differences. Next slide, please. In terms of harms, there's not really big differences between the two groups. Hyperkeratosis, which was of interest because of the potential for this happening because of the nature of the mechanism of the agent, was 1.4% in one treatment group, 3% in the other treatment group, and less than 1% in the placebo group. There weren't large differences in serious events between any of these groups. And there were 14 deaths in the whole study, none of which were deemed to be related to treatment. Next slide, please. In terms of the sources of uncertainty, I mean, again, I'm not sure. So whether this helps less symptomatic people. There's a lot of people that have bronchiectasis on a CT scan that very well may become symptomatic or develop this. It's not at all clear whether brensocatib would help such individuals. And then on the other side, does it help people that are really severely ill, people who have FEV1 less than 50% or BSI greater than 9? It's underpowered to detect such differences, but if you look at the forest plot, the midpoint of the range is near unity, so it at least suggests that it may not work in such subgroups. Are there different effects in children? There's very few adolescents in this trial, very wide confidence intervals in terms of the subgroup analysis. The midpoint of that range is not near unity, but it's such a wide confidence interval in the setting of statistical uncertainty that it's hard to tell. And then patients really told us one of their real hopes is to reduce the need for long-term antibiotics. A lot of these antibiotics have side effects for the individuals, but also for society in terms of antibiotic resistance. Does brensocatib reduce the need for both antibiotics and airway clearance? And is there an additive benefit over time with reduction of lung tissue destruction? This is incredibly important for patients. This is a progressive disorder. Again, lung tissue, lung function is worsening in all the groups, placebo and the two treatment groups, maybe a little bit of less worsening in the 25 milligrams brensocatib dose. But how much is that important? Over time, are you going to see nonlinear effects and progressive effects? That's an optimistic view. Maybe over time, you're going to see even larger benefits, but that's empirically unproven. And does this really affect daily symptoms other than annualized exacerbations? Patients don't like exacerbations, but they also don't like the daily symptoms. There seems to be some small difference, but overall, this appears like a relatively small difference in terms of magnitude of questionable clinical importance. Next slide, please. So in terms of benefits beyond health and special ethical priorities, there's no real disease-specific treatment for this. So this is a really welcome, exciting development for many in the community. There aren't yet clinical practice guidelines specific to the United States. There are in other countries. Brensocatib has the potential to reduce. It's a pill. You just take the pill. It's not an airway clearance device or something that requires equipment or lots of time. So there is a potential that using this medication may reduce the needs for these things, but again, that's empirically unproven. It's conceptual, and an optimist would hope for it, but it's hard to prove empirically. Brensocatib may reduce the need for these therapies that patients find so life-changing and so burdensome. It would be amazing if that was the case, but it's unclear empirically. Next slide, please. In terms of public comments, we really do take the public deliberation process very seriously, and the manufacturer kind of really pushed back about our comments about MCIDs, and so we've changed the text, and I've tried to really capture the nuance with these MCIDs. That in one case, we're borrowing an MCID from COPD because none exists for this condition. And then in the other case, there's an ambiguity in the way that the MCID has been used in the past, relative change from baseline versus difference from placebo. The analytic problem is that the placebo group gets a fair bit better themselves. So it's unclear which to use. And we've been very precise about these ambiguities in the current version of the report. But I think there's no getting around that these differences are pretty small. Next slide, please. So in terms of this key comparison, brensocatib versus plus usual care for adults and adolescents with NCFB, there's likely an incremental or possibly substantial net benefit in a well-designed international large trial that was double-blinded. So that's like really good news. But the magnitude of such benefits appears relatively small, especially in terms of daily symptoms. So we think it works, but it's a pretty small benefit. There mechanistically and pathophysiologically, there is a conceptual possibility, a real possibility and hope of additive benefits over time, that maybe this becomes a very large benefit over time, but that's as yet unproven. We will see. This has been only FDA approved for 6 weeks, so we'll have to see with real world use. And there's not really any meaningful evidence suggesting harm of brensocatib. So that's another bit of good news. Next slide, please. So in the setting of, we're pretty sure that this has at least a small benefit, and there's conceptually hope of a large benefit. We think a harm, for example, is ruled out. We gave it a B+ evidence rating. Thank you all for coming today and listening, and we would love to answer any questions if you have them.
Thank you very much, Jason, for a very terrific and lucid presentation evaluating this drug. At this time, I'd like to open it up for our CTAF panels for questions for Jason or our clinical experts. Dr. Phillips.
Yeah, that was great. Thank you. Tell me more regarding how you chose which outcomes to measure, because this disease has many different facets to it, and there are multiple outcomes. And there's a severity index that was used to determine who was in the trial. But then when you did the trial then had just this list of outcomes that were being measured. So could you talk about the multifaceted nature of the outcomes and how we could think about that, given that there are so many different outcomes?
Yeah, and I appreciate, thank you for your kind comments and appreciate the importance of the question. And one complexity here is that because of the pre-specified statistical analysis plan, there was a hierarchical process. So you can kind of blind yourself to the plan and say, oh, this is different. But because they had to specify the hierarchy of testing, they didn't necessarily make claims about differences. But I think in listening to patients, we do think all these things matter. Patients don't like exacerbations. So exacerbations happen in the outpatient setting. Probably a minority of them lead to inpatient care, maybe 10, 20%. That's about the rough proportion. So the primary endpoint, I think, is meaningful to patients. We heard over and over, though, that daily symptoms are very fatigue, cough, the impairments of daily life. So we wanted to include those as well. And then we also acknowledge that the preservation of lung function was very important to the patients. It was important to the clinical experts that we spoke to. Some of the people here today as well gave us a lot of feedback about that. So we do think that citing the FEV1 data is important. And then there's interesting questions over time of what that means. Ultimately, what happens to patients is really all that matters, but you can use the mechanistic data as a way to intuit the potential for future additional benefits. And I think that Paul.
Paul, did you want to add to Jason's comments here?
A separate.
Oh no, I'm sorry, Dr. Eifenbach. We have two Pauls going here.
Sorry, I just wanted to add that there's also a sense in which, and Dr. Askamed probably can speak to this too, but a sense in which exacerbations is a surrogate outcome, in the sense that exacerbation rates, frequency of exacerbation, severity of exacerbations are all linked to prognosis in patients with bronchiectasis. People with more exacerbations develop worsening lung function over time and develop more severe disease. These are, of course, to some extent association studies, although also plausible based on the mechanism of disease. There's kind of recurrent lung injury in the setting of ongoing low-grade or active infections. And so so I think exacerbations in this case is both an outcome measure that's important to patients, and it is standing in as a surrogate measure for some other long-term things that that this study was not long enough or powered over this kind of time frame to study.
Thanks, Paul. Kavita.
Thank you so much, Jason. I wanted to just follow up on one of the takeaways that you had talked about, where this therapy could potentially reduce the use of some of these other supportive treatments to reduce, the formation of mucus. This is not my disease area, which is cumbersome, right? You've got equipment that is used to clear your lung function that takes time out of your day. And you said this could potentially, and if I'm not, I don't want to put words in your mouth. And so the current trial evaluated this agent as a add-on therapy. And so can you talk a little bit more about what the patient feedback was about? Could this potentially be standalone, or going forward as the first FDA-approved oral therapy? There's lots of things involved in that, right? Oral, potentially approved therapy. What the implications could that be? And maybe that was, I'll end on this note, maybe that was related to the fact that there needs to be additional investigations into this as a standalone, larger trial. Because I think there's some value to be, if I'm hearing you right, to say that we need more investigations to see the greater power, bigger populations.
Yeah, I mean, I think, right, there's always a feasibility issue with randomized trials about like how large they can be to detect differences that matter. But yeah, that's exactly correct. So to be clear, in this trial, the standard things were in both arms. So the placebo arm and there's 3 arms. In both treatment arms and the placebo arm all had these cumbersome regular therapies. But with time, conceptually, I just want to be very cautious here because I'm not making an empirical claim. We don't know yet, to your point. These therapies may become less needed if brensocatib works in a way that spares them. But that's a conceptual promise that's unproven, but would be welcomed by the patient community to what we understand. And I think other people have, Dan Ollendorf, do you want to weigh?
Dan, do you want to add your perspective?
Yeah, thanks, Ralph and Jason. So I really just want to bring up, and this is primarily for those who are not as familiar with our process, we do go through about a 5-week time period in which we're reaching out to members of the patient community, patient advocacy groups, clinical experts, representatives from the payer community, the manufacturer, to really try to understand what sort of outcomes we should consider in scope, what are the most important outcomes. And that's an intentionally distinct process from actually looking at what was measured in the clinical trial. So then you'll see in the report, as you've seen in this one, where there are outcomes where we think that there's evidence to report on, we do that. And when there are others where there's evidence that is either not considered sufficient or is still to come, we'll also say that. So I just want to make sure that everyone understands that the process of scoping and identifying those most important outcomes is somewhat separate from looking at the evidence itself.
Thanks, Dan. Paul, you've been very patient. Dr. Heidenreich.
Yes, thank you, Jason, and great overview. My question is about the small potentially clinically not important differences. I think you said an FEV1 and symptom score. I'd say this could be due, right, to either everyone getting a very small benefit or a few people getting a large benefit. The latter actually may be very important for some patients to be able to have that opportunity. Is there data to say, which one of these led to the small mean value seen?
Right, yeah, and actually I'll also add Paul, and I appreciate the importance of the point. I think this actually was also a point raised by the manufacturer, and this is one of the concerns about using average treatment effects in trials to compare against an MCID. It's a thoughtful point that some people, like some proportion of the individuals, likely had a large benefit and others had a smaller or no benefit. So I don't know what proportion of the patients within the trial had differential levels of benefits. I'm just checking this, but I believe that's correct. So that is a limitation to any claim about average treatment effect being relatively small, as you've very appropriately stated.
Dr. Axamit, our clinical expert, you want to add to this discussion? You're on mute.
Can you hear me now? Can you hear me?
Yes.
I just wanted to emphasize, I think that the exacerbation endpoint is the right endpoint to use here. We know in this cohort of individuals, NCFB bronchiectasis patients, that individuals that have exacerbations are more likely to have more exacerbations, and they've been very tightly correlated with outcomes, whether it be mortality, hospitalizations, rate of loss of lung function, and assorted numbers. So I think exacerbation rate is the proper endpoint here. Having said that, I think I want to also emphasize a couple of other points. One is that with most phase 3 studies, and this held true with other phase 3 inhaled antibiotic trials in this cohort, that the event rate in the placebo group will go down. And that doesn't take away at all from the therapeutic advantage of whatever the intervention is, but we understand that doing the simple things and having patients enroll in trials will lower the event rate, and that's been a consistent signal that we've noted all along. And then if we take one step back and just to understand that we're really looking to see what individuals that have symptoms vis-a-vis increased exacerbations going into the study do with this medicine, when in fact, if we're really going to adjust or alter the natural course of the disease process, it'll be really important at some point to try to get early disease management with the intervention for this. That was not the purpose of this trial, but I just wanted to put that into the context. And the context also is that this study isn't the ends, if you will, but it's a beginning to open up, I think, a pathway for solutions, as Sarah had said, and to have additional investigations, not only with the DPP1 inhibitors, but lots of other therapies that are coming down the pathway. So this is really an opening salvo, if you will, to what many of us believe is going to be an explosion of investigations to answer some of these more important questions. Although the data that we have with the exacerbations, I think, speaks for itself, and I would endorse that that's the right endpoint. Thank you.
Dr. Axamit, thank you so much for those terrific comments. I'd like to turn to John Torrance, our patient, for a patient perspective.
Thank you very much to the group. As background, I'm a bronchiectasis patient. I've been in this world for about 16 years. I've spent half of the last 13 years on antibiotic treatment as a result of infections that I've gotten secondary to the bronchiectasis. So I do speak from ground level experience. I'd like to comment specifically on, there was a slide that talked about even patients who are on placebo seem to make progress, and that seems a little bit odd, but there's a background that you may be missing, that there was a comment about part of our daily activities, this concept of airway clearance. Airway clearance is us physically trying to get the junk out of our system. It's a process that can take anywhere from 1 to 3 hours a day. It's physically exhausting. It's humbling. I think it was designed by somebody who previously worked at a prisoner of war camp. I have told people this, and this is humbling to me personally. Only an optimist does airway clearance because it's hard work. and it's an investment in the future. And candidly, as patients, half the time we are not optimists. We do not feel good about ourselves. You heard it in some of the comments. So when you're part of a trial and fancy medical people are paying attention to you and they're giving you the possibility of a future, you're more likely to adhere to your airway clearance protocols. So the group that you're saying is a placebo group was actually benefiting just from the extra attention they're getting from the medical community. But in the normal bronchiectasis group, I would say half to 2/3 of our group do not do the prescribed level of airway clearance because it is so hard and so exhausting to do. So thank you very much.
John, thank you so much for being here in those comments. Dr. Redberg.
Thanks, and I'll add great evidence review and discussion. And I think others mentioned it, and thanks for the comments just now from John, from a patient perspective, which was helpful, because I was struck that it was a small difference. 49% remained exacerbation free in the treatment group and 40% in the placebo group. And the quality of life, which was really a very small, kind of a narrow focus, 1 of 8, it said, of the bigger quality of life domain. So I might have expected a bigger impact because it was narrowly focused on bronchiectasis and still seemed like a small change, though I certainly hear more optimism from the patients, and I understand the eagerness, of course, to have a simpler and more effective treatment. But I am concerned about the small differences between the placebo and the treatment groups. I also wondered if any of the experts would comment on why I know there were 14 deaths and there were 7, it seemed, in each arm, but the average age was 59 in this study. So that seemed to me to be a higher rate of death than I would have thought in a 500 each in those arms, and wondering if you would comment on what the causes of death were. And I know they were deemed not related to treatment, but what were they related to?
And I might just add that this is a sick group of individuals in the sense of they do have significant disease and they do have increased morbidities and mortalities. So whether that's related to respiratory deaths or other deaths, this is a population with a huge unmet need. And just as one reflection of that is they do have an increased mortality rate relative to others. And that's been correlated well with severity. It's been shown in the US registry. It's been shown in the European registry and other registries around the world. So I'm not sure that this is unexpected, because this is really a group of individuals that have a large burden, as John says, of disease. And we need to try to make an impact on that trajectory, if you will. And most importantly, for many of us, myself included, we also, as that caveat, is we wanted to have disease early so we don't get to this point where we have this increased morbidity and mortality. Thank you.
Dr. Diefenbach, you want to add to this?
Certainly, there are, bronchiectasis is a very heterogeneous disorder. We often lump it together as non-cystic fibrosis associated bronchiectasis, but the underlying causes can be many, and the severity of disease is widespread. Somebody that has 3 or 4 or 5 exacerbations a year and a very large lung burden is certainly at risk of intubations and deaths in the setting of ICU care from any severe exacerbation. And recurrent infections cause increased inflammation in the body and put these patients at increased risk of heart disease and endocarditis and your list of various problems. I also wanted to comment. There is sort of an optimist and pessimist take on the kind of improvement seen in the placebo group with regards to the therapy. In this group that had 2 exacerbations in the previous year, they went down and the annualized exacerbation rate decreased to about 0.5 exacerbations annualized per year. This probably does have to do with some regression to the mean and some of the robust use and optimistic use by the patients of their regular airway clearance regimen are probably the two things. One thing worth noting is that aggressive, very painful airway regimen it is the cornerstone of therapy and probably has at least as large an effect as that, and probably larger effect than this drug. And so this drug seems unlikely to replace that. Regarding another question, but at both sides of the confidence interval, the 3 to 18% absolute risk reduction in patients that have half of an exacerbation per year on average means that if they had in patients that are sicker and had maintained 1.5 to 2 exacerbations per year, so 3 or 4 times the rate, usually the relative risk reduction is similar, regardless of severity, in most medical trials. And so you might expect a 2, 3, 4 times as much, so somewhere between 10 and 60% absolute chance of at least 1 exacerbation fewer in a year in patients with a higher annualized exacerbation rate. So you can look at it both ways.
Thanks, Paul. Cy.
Thanks, Ralph. So I have been kind of turning around in my head this idea of, a couple of thoughts. One that Dr. Diefenbach mentioned about how there's such a wide spectrum of disease. Something that Jason mentioned in his presentation about if you do more CT scans, you'll find more bronchiectasis. And so I'm wondering about the spectrum of disease severity and whether a study like this that is generally going to be run out of larger academic medical centers, that is the data that we have. And are we going to be appropriately applying this to a much larger group of patients for whom the spectrum of disease severity is going to be substantially different? And just thinking in terms of if the patients are actually at lower risk, then they are likely, the hyperkeratosis doesn't seem to be associated with the underlying disease, and therefore they may be at just as high risk of the adverse effects, but their absolute benefit and absolute risk reduction is going to be lower. So was wondering about the disease severity issue and whether kind of I'm off base there.
No, I mean, I think these are exactly the right questions. So there's uncertainty on both sides, which is to say that, right, so it's very clear that the more CT scans people get, the more diagnoses you make. So that's mostly a good thing, right? The people who are thought to have other things that actually have NCFB that are discovered when they properly have a CT scan. But conceptually, there's another issue too, which is that you can have a CT scan for following an aortopathy, and then you incidentally see bronchiectasis. And for those individuals who genuinely do not have symptoms or very low symptoms, I would say it's entirely unclear whether brensocatib is helpful or not. You could conceptually again see, oh, maybe I should take this so I don't get the syndrome in the future, but that's entirely unclear from the data here. And then conversely, on the other side, among people who were included in the trials, the more severe subgroups, again, in the limitations of a statistically underpowered subgroup, don't appear to have much benefit either. So I think these are exactly the right questions, and there's uncertainty on both sides.
And I might just expand on this heterogeneity theme, which has been pervasive through our experience in this cohort of individuals. And that's one of the reasons why we think many of the previous phase 3 studies looking at investigational agents for NCFB patients have not been positive. And just to put this in perspective, it's not uncommon to have comorbidities or other diagnoses, as has been mentioned. And there is a spectrum of disease from very mild incidental disease to clinically significant and important disease. Now, the issue is, where do we make that intervention? And I think that these are all questions that are not answered by the current ASPEN study, but will be answered by hopefully phase 4 studies when we get real world experience going into this, to try to begin to sort out some of the opportunities at hand. And just to put this in perspective, numbers wise, many of you are familiar with the GOLD report, the COPD obstructive lung disease report, and the most recent report that came out in 2025 had upgraded the finding of bronchiectasis associated with COPD ranging between 20 and 69%, with I think a quoted number of about 54%. Point is that there's some bronchiectasis that is incidental. There's some that is standalone bronchiectasis, and then there's probably a larger group of overlap, if you will, whether it be with COPD and asthma. And we don't know exactly where this fits in, and that was not the purpose of the ASPEN study, but certainly something that most of us will be eager to address in the real world experience as we go into phase 4 analysis. Thank you.
Thanks, Tim. Paul, closing 60-second comments?
Sure. I'll just say, on the again, from a disease severity perspective, what this trial best studies is rates of exacerbation. It's about a 20% risk reduction in rates of exacerbation, and typically speaking, that relative risk reduction is going to be similar across groups. So if you have patients that are milder and have very few exacerbations, half as many as this cohort did, then your expected absolute reduction is going to be somewhere in 1.5 to 4.5% of people would be spared an exacerbation, rather than the 3 to 18 seen in this group. And if you had people that had twice as many exacerbations a year, you'd expect twice the absolute benefit, if you want to think about it that way.
Thanks, Paul. Jason, did you have a clarifying comment before we move on?
Yes, I'm sorry. I know we're short on time. I just I didn't fully answer Dr. Redberg's question about causes of death. She probably noticed that. We just were going through the appendix to try to get the information. A couple of us were actually. And so in terms of causes of death for the 10 milligrams brensocatib group, it was aspergillus, acute respiratory failure, and bronchiectasis. In the 25 milligram dose, pneumonia, MI, general physical health deterioration, and road traffic accident. And then there were 7 deaths in the placebo group: pneumonia, respiratory failure, bronchiectasis, hemoptysis, cardiac arrest, cardiorespiratory arrest, and cervical vertebral fracture. So we do have causes of death. Obviously, there's no statistical power to make comparisons.
Sure. Thanks so much, Jason. I appreciate that.
Yeah, Jason, thanks for digging that up and passing that on. Great discussion. Thank you, everyone. At this time, I'd like to turn over to Dr. Ki-Boon Kim, who's going to give us a presentation on the evidence and economic modeling.
Thank you. Can you hear me okay?
Yes.
Yeah. Thank you. And I appreciate the introduction, Dr. Brindis. And it is such an honor that I can share our assessment on the cost effectiveness of the innovative treatment strategy. I'm Ki-Boon Kim, Assistant Professor of the Pharmacy Systems and Outcomes and Policy at University of Illinois, Chicago. Next slide, please. A UIC team of faculty and research staff, including Dr. Daniel Touchet, the senior investigator, and Sonam Kim, contributing a significant effort to the model development and operation, have been working together on this assessment. And I also want to acknowledge Marina Richardson and Mary Phillips at ICER for their leadership and contribution. Here's our disclosure. Next slide, please. The objective was to evaluate the lifetime cost effectiveness of brensocatib as an add-on therapy to usual care compared to the usual care alone for the treatment of non-cystic fibrosis bronchiectasis. Next slide, please. Thanks to ICER economic assessment lead about the analysis of unmet need, absolute and proportional equal value life year shortfall were calculated here, there are significant level of unresolved quality and quantity of life. NCFB is associated with 37% of shortfall EVLY compared to the matched US population at similar age, meaning the estimated burden and the quality quantity of life is significant in patients with NCFB. Next slide, please. The research team developed a decision tree and Markov cohort simulation model running on a monthly cycle over a lifetime horizon, considering NCFB is a chronic pulmonary condition that impacts throughout patient life. Running this assessment, we anticipated that NCFB patient would receive the assigned treatment throughout their lifetime to avoid any immediate loss of clinical benefits. The primary perspective was United States healthcare sector's perspective for the base case, and we also analyzed the cost effectiveness under a modified societal perspective as part of the scenario analysis, and the modified societal perspective analysis did not meet the criteria for the core-base case analysis. For the long-term outcome projection and simulation, 3% annual discount rate was applied for both cost and outcomes, and the outcomes included cost per life years gained, cost per quality adjusted life years gained, and cost per equal value life years gained. We also analyzed the number of exacerbation and cost per number of pulmonary exacerbation averted by the use of brensocatib. The inclusion of this clinical outcome makes sense from the clinical perspective, and we directly incorporated the clinical outcome into the cost effectiveness projection. Next slide, please. The impact of brensocatib in addition to the usual care versus usual care alone was assessed using the de novo model here, where patient transit between the non-exacerbated to the exacerbated state on a monthly cycle basis. Exacerbation rate and the status were combined with the chronic infections, including Pseudomonas aeruginosa and non-tuberculosis mycobacterium infection, which both impose significant clinical and economic burdens in the NCF management. To operate this model, we identified and utilized several inputs, including impact of treatment strategy on the risk of NCFB exacerbation or risk of chronic infection, and impact of chronic infection on the risk of exacerbation, impact of the infection and exacerbation on the overall mortality. Also, cost and utility of each health states were identified and utilized. Next slide, please. The target cohort was a patient population including adolescents and adults with NCFB. We compared the brensocatib plus usual care and the usual care alone for the patient matched with clinical trial population. Briefly, patients are on average around the 60-year-old, and female to male ratio would be of around 64 to 36%. Patient had a history of 2 or more pulmonary exacerbations prior to the model entry, and around 30% of the patients were assumed to have 3 or more exacerbations during the 1 year prior to receive the treatment. 35% of the target population were classified as a Pseudomonas aeruginosa culture positive that matched with the recent clinical trial cohort. And we used the weighted average to patient characteristics inclusion across the intervention and comparator. Next slide, please. Our economic outcome assessment was performed on several key assumptions. First, pulmonary exacerbation was the primary outcome and a primary mediator in our model output calculation. Because clinical symptoms of NCFB are likely to worsen with a chronic infection, our model-based approach reflected the higher risk of exacerbation from the infection state. Second, 25 milligram once daily was our treatment for the base case simulation. Since the brensocatib 25 milligram slowed the loss of lung function compared to the placebo, and the delay in the loss of lung function with 25 milligram was significant. The lower dose of the 10 milligram and its outcome was tested in our scenario analysis. For the discontinuation and adverse event, many input values were identified from intention to treat analysis, which already included adverse event and discontinuation as part of the assessment. In addition, the proportion of individuals with adverse event were similar between the two treatments. Therefore, we decided not to incorporate the impact of adverse event on outcomes as a separate input factor, while we adjusted the rate of discontinuation for the cost calculation. Next slide, please. We also assumed that the majority of patients would be recovered from an exacerbation state within a month cycle. The assumption was supported by our discussion with the clinical expert, although we generally agree that a subset of patients would experience the exacerbated status longer than several weeks. Lastly, for severe exacerbation, as defined by the need of infusion therapy and extensive care, we assume that such subset of exacerbated patients need inpatient care. Additional healthcare costs and decrease in health utility for the severe cases were applied on top of the cost and utility of less severe exacerbation state. Next slide, please. For the model operation, we identified and utilized inputs across three key areas: clinical outcomes, quality of life, and healthcare cost. The annual rate of exacerbation and the risk ratio of the exacerbation were directly abstracted from the recent clinical trial, and we calculated monthly rate from the annual rate. From the trial report, 14.7% of all exacerbations were reported as severe, which we assume to be managed in a hospital setting. Since the 95% confidence intervals of the proportion of the severe exacerbation overlapped between brensocatib and placebo usual care, our base case analysis used the same exacerbation hospitalization rate for both treatment and comparator, but we tested the impact of the decrease in the rate of hospitalization with brensocatib using our sensitivity analysis. Also, the model reflected the potential difference in the chronic infection rate across the treatment strategies. To reflect the model assumptions, the increase in the risk of exacerbations was higher with the chronic infection for our simulation. Next slide, please. Here is the summary of the health state utility inputs. From the literature search, we found the paucity of evidence on the generic health utility measures for quality of life calculation. For this reason, we firstly abstracted a disease-specific health score for each health state, then converted those numbers to utility weight using a published algorithm. Then here are the utility weight we calculated and used for the model that outlines the decrease in the quality of life with the exacerbation, infection, and severe exacerbation that need hospital admission, on top of the already low quality of life for the patient with ACFB. We also wanted to discuss the external validity of our utility inputs. The numbers we identified and calculated are comparable to the inputs for the previous cost effectiveness models and outputs, which means the input we already have been externally validated. Next slide, please. For the treatment cost, we used the placeholder input obtained from a recent press release. The cost for NCFB usual care, exacerbation, hospitalization for managing severe exacerbation, and chronic infection were identified from literature review. Then we recalculated monthly inputs if the unit period from the published study differed from our model cycle. All the costs were inflation adjusted to December 2024. Next slide, please. Let us see how all the model inputs resulted in the outcomes over the lifetime horizon. The final evidence report presented the direct healthcare cost that aggregates intervention-related costs and the non-intervention costs for the exacerbation and the chronic infections, and how the decrease in the pulmonary exacerbation or less chronic infections create the cost offset. The healthcare costs for the Bronchiectasis and usual care strategy are presented in the total cost column on the left side of this table, and projected effectiveness, including quality of life years, and equal value life years, and the number of pulmonary exacerbation from left to right. The total lifetime cost of healthcare following the Bronchiectasis is 1.15 million. This was higher than the cost estimate from the usual care strategy of 367,000. For the effectiveness outcomes, the decrease in the pulmonary exacerbation and chronic infection resulted in the quality adjusted life years and the equal value life years gained and saving life years as well. The discounted life year estimate was around 13.7 years for both strategies and slightly better off with the Bronchiectasis. After adjusting for the quality of life, quality adjusted life years and EVLY were estimated around 9.32 for Bronchiectasis and 9.18 for usual care. Next slide, please. Using the direct cost and effectiveness estimate from the previous slide, we here can calculate the base case incremental cost effectiveness ratio for Bronchiectasis compared to the usual care alone. The estimate were around $5.6 million per quality adjusted life years gained and 5.2 million per equal value life years gained. Next slide, please. To account for the uncertainty around the model inputs, we ran multiple sensitivity analysis, and this slide presents results from one-way sensitivity analysis showing how changes in each input has an impact on the incremental cost effectiveness ratio calculation. The most significant uncertainty impact was calculated or observed from the relative risk of both chronic conditions, which is corresponding to the clinical expert concern on the burden of chronic infection among the patient with NCFB. Then the relative risk and utility impact of pulmonary exacerbation also have a significant impact on the incremental cost effectiveness ratio. Overall, the lower bound of the incremental cost effectiveness ratio could not fall below $4 million per quality adjusted life years when we assess the Bronchiectasis plus usual care versus usual care alone. Next slide, please. Probabilistic sensitivity analysis provided us with some insight on what if we varied all the inputs simultaneously using our model and how this impact on our cost effectiveness discussion. For this analysis, using 95% confidence intervals or anticipated ranges of input values, we recalculated incremental cost effectiveness ratio 1,000 times and took the proportion of the simulations that meets commonly published and utilized threshold willingness to pay. We see the 0% of simulation met those thresholds up to $200,000 per quality adjusted life years or equal value life years gained, which means in 0% of our simulation, Bronchiectasis is preferred. Next slide, please. We also leverage the scenario analysis as a method to address the uncertainty on or heterogeneity of the outcome. Here are the selected scenario analysis results. Firstly, NCFB imposes a significant burden, not on the healthcare sectors only, but can decrease the productivity in both patient and caregivers. This results in the indirect cost to society. So we incorporated such indirect cost into the model simulation by using US average wage rate and anticipated number of days absent from work. From this scenario, we concluded that the results from the modified societal perspective was not far from our conclusion from the healthcare sector perspective. For the uncertainty of the clinical inputs and potential heterogeneity of the cost effectiveness across the patient group, we calculated the incremental cost effectiveness ratio after replacing or combining inputs from various resources. Of the scenario analysis result, the incremental cost effectiveness ratio largely decreased when our model incorporated the impact of delayed lung function loss with the brensocatib. Also, running a simulation for the real-world patient having serious conditions with higher mortality and increase in the cost of hospitalization when exacerbation happens, we could calculate the moderate decrease in the incremental cost effectiveness ratio compared to the base case simulation result. Next slide, please. Using our model inputs and projected cost effectiveness, benchmark price could be calculated at the threshold of $100,000 and $150,000 per quality-adjusted life years gain and equal value life years gain. Our range was around $3,100 to $3,700 per year, which is quite lower and requires larger discount. Next slide, please. Because NCFB is still an area of clinical investigation and we are on the frontier line, the limited data on clinical effectiveness of treatment options and absence of NCFB-specific mortality information raised concern on the uncertainty around our inputs. Also, caregiver burden and disutility were not included in our model. This was because the similarity in the patient daily symptom scores between the two compared strategies that would not be translated as a difference in the caregiver burden. And we need further evidence to discuss the caregiver burden for the economic outcome assessment. We hope and anticipate to see additional evidence in near future that will advance our approach in assessing the outcomes of treatment strategies in patients with NCFB. Next slide. I appreciate the constructive public comments that help us improve the quality of our study. There are several key comments on our draft report, including the inputs underrepresenting the real-world cost of pulmonary exacerbation and lacking caregiver loss of productivity inputs when calculating the cost from modified society perspective, and needs for addressing heterogeneous real-world scenario, particularly some severe real-world cases. In response to the comment, cost of exacerbation and caregivers' loss of productivity inputs have been updated for the final evidence report and for this slide as well. And we also compiled the potential inputs from studies that analyze severe real-world population, then tested the impact of brensocatib on the severe subpopulation in scenario analysis. Next slide, please. In conclusion, treatment with brensocatib add-on to usual care strategy resulted in lifetime improvement in quality of life through reduction in the number of exacerbations and chronic respiratory infections, and result in higher cost, primarily because of the cost of the treatment compared to the usual care alone. At the current place order treatment costs that include the anticipated range of the discounting, brensocatib would not meet the commonly used cost effectiveness threshold, although the improving clinical outcomes and quality of life is evident. Next slide. Thanks for your listening, and I appreciate your attention and questions.
Thank you very, very much, Dr. Kim, for that thorough analysis on the cost effectiveness of our medication under discussion today. This time, I'd like to open it up for questions or comments from our CTAF panel. Dr. Phillips.
Yeah, thank you very much. Would you go back to scenario 3, which is the one that was more promising? And I would it be useful to talk a bit more about why that had a better ratio? And is there anything that we can take from that? That was the decline in lung function.
Yeah, I think you are talking about our scenario on testing impact of the brensocatib on decline in lung function.
Yes,
They
yes.
actually decrease the cost per quality adjusted life years gained a lot. So there was a kind of the significant amount of the discussion on, do we have to include the independent impact of the brensocatib on decline in lung function or not? Because the delay in the lung function decline may be mediated by the exacerbation, or it can be completely independent from the less rate of the exacerbation after receiving the brensocatib. So it is unclear. That is why we included the exacerbation impact on the quality adjusted life change as a base case. And if we add the delay in the lung function decline on top of the decrease in the exacerbation rate as an independent factor into cost effectiveness model, then we can see additional decrease in the incremental cost effectiveness ratio. But we basically need additional evidence on, can this become a base case analysis or not? Because we are not completely assumed that the delay in the decrease in the lung function is completely independent effect.
I just want to, I know that Jeff has his hand up. I just want to jump in for a second and just tag on. So just a reminder that one of the other reasons we made this a scenario rather than a base case analysis reflects back on what Jason mentioned, that there was a smaller decline in lung function in the 25 milligram group. Recognizing that the MCID data is borrowed from COPD, it was a very modest difference. And so there are still open questions about whether that is a clinically meaningful change.
Yeah, thanks for pointing out that. How we can translate this one into the quality of life is still a debatable issue.
Thanks, Dan. Jeff?
Thank you. Dr. Kim, thanks for your model and for going through it. Looks like it's a lot of work, and you've tried very hard to be very careful. And I had some questions understanding. Tell me if I'm understanding the main message. It looks to me like if we're measuring outcome in terms of a longer life, that we don't have a lot of extra years of life. And if we're measuring outcome in terms of quality adjusted life, we don't have a lot of extra qualities either. And paying a whole lot for not very much doesn't seem like a good deal. That's the first part of my question. Am I understanding that so far correctly?
Yes, you are perfectly clearly understand the message from here. But what I want to point out is that the relative cost increase is way larger than the small gain in the quality adjusted life years or the life years gain.
Perfect. So the question I want to follow up on is, it looks like if we use a different outcome like exacerbations, that there is a larger gain. It's about 3. And I wonder if you can help us appreciate, can I assume that the quality as the measure of outcome kind of captures exacerbation and the quality of life impact? Or is there something special, different about exacerbations that's not being captured in the quality?
Okay, that's an interesting question. And I think it's more kind of relevant to the clinical sector, because how long the exacerbation or the patient stay in the exacerbation is actually involved in your question. The patient stay in the exacerbation for like a year, then it's going to have a significant impact on the quality of life. But for our model, and based on the expert judgment and the communication, we assume that exacerbation stayed for about a month, and then majority of the patient will be covered back to the non-exacerbated state. So that is why we provided two different measures. One, quality adjusted life years and EVLY, as well as we try to count the anticipated decrease in the number of exacerbations. That may be more kinds of the clinically relevant or the patient perspective relevant questions. But for the long-term outcome projection and the value evaluation, we would love to use the quality adjusted life years and EVLY as a metric.
So if I'm understanding you correctly, no matter how bad, awful exacerbations are, because in the model it only lasts for, let's say, a month. It can be bad, but it doesn't really count for that long because it's only 1 month.
Yeah, unfortunately, that's the assumption, and that's the scenario that we evaluated.
Thank you.
Maybe John, as a patient expert, you could give some perspective and ground us a little bit related to this discussion.
Thank you. I'd like to do that. I mentioned previously about half of my last 13 years, I've been on triple antibiotic therapy, including a full year of intravenous drugs, which means I'm tied to a pole for long periods of time. I've spent years not able to actually pursue life, just tied to medical treatments and things like that. I've had surgery to remove part of my lung. I think I'm somewhere in the middle of the group. I've talked to thousands of patients. Some have much more severe treatment than me. Some have much more mild, but I'm somewhere in the middle. And I would hope Amy would like to comment on this when I'm done for her perspective. But if we go back to that opening comment when we first met this morning, there was a woman who had left that quotation about she really had no chance to go out and live at all because she lived in fear of the infection. And I did the first 2 years. I didn't go out. I only did medical things. And I finally decided that was no life at all. And now I go out and I live my life, but I know that I'm going to get an infection. So the idea that there's something that might get that life quality up, to me, has a lot more value than just the number of years. I'm going to travel. I know I'm going to get an infection. I'll pay the price, but I still want to be part of this world. So that's my comment. And I'm hoping Amy has a comment as well.
Thanks, John.
Yeah, sure. So I think I'm going to start with a comment on what an exacerbation is and what it's not. It's not an asthma attack. It's not a cold. It's not even just a simple pneumonia. And I think a month for a lot of patients is optimistic. It's been my experience, not just with my own family member, but our organization runs 48 support groups. And we staff almost all the meetings, so it's more than 20 meetings a month. So we hear from a lot of patients who discuss their health regularly, and they discuss their exacerbations. This is a long time event for them, and sometimes it involves hospitalizations or trips to the ER as well. And that's not even a surprise. That's a consistent story that we hear. And then there's also, the aftermath of the exacerbation. Lung tissue is not, unlike liver tissue, it doesn't regenerate. So once that damage is done, it's done. It's permanent. You don't get your lung back. So the point in reducing the exacerbations is to help prevent that decline in lung function, that degradation of lung tissue. And if we're going to talk about what we don't know yet, that's true of every single drug that comes to market. We don't know yet. But what we are seeing so far is the one thing that patients have been focused on is, reducing those exacerbations, because in the patient's mind, and this is something that I will bring out later with patient comments, they understand these exacerbations as tied to a decline in their quality of life, tied to a decline in their lung function, tied to an increased risk of infection. It ties into all of it. And so they very much have wanted for a long time, and they have expressed this repeatedly, and we have quantified this as well. They have expressed that they want something to address the inflammation associated with bronchiectasis because of these exacerbations. This for them is something that they dread because they don't know how it's going to end. And they don't know if it's going to, cause something like hemoptysis, which is, another effect of exacerbation, which again, a lot of things aren't taken into account in this valuation, which are part of the everyday experience, the lived experience of the patient, the infections, the hemoptysis, that uncontrolled bleeding. People think, oh, you're just coughing up some blood. Well, no, we know of at least 2 patients who've died from that uncontrolled bleeding. These can be very difficult and life-threatening events as well. So there's a reason these patients don't want this to happen. There's a reason the doctors who treat these patients don't want these exacerbations to happen. And it goes beyond just not wanting to cough and not wanting to deal with the inflammation. There's a cascade of effects from
Thank you so much, Amy and John, for your comments and grounding this discussion. Tim and Paul, do you have some direct comments? I do want to make sure we ask some questions related to the modeling here. Tim, you're on mute.
I just wanted to expand on this presentation by Dr. Kim. Did you take into account age of onset of bronchiectasis and the potentially favorable impact that this intervention had over a lifetime if you're starting at age 20 versus starting at age 60? Was that taken into account in your modeling? Thank you.
So in terms of the cost effectiveness projection using the model, we ran the sensitivity analysis within the range of the age that we can get within the 95% confidence interval range, but which is not as large as what you anticipated. So the age impact on the outcome is limited, captured in the limited way. But the heterogeneity across the whole different patient characteristics or the outcome is incompletely captured.
Thanks for that question, Tim. Paul, did you have a question or comment to Dr. Kim?
Yes, sort of a combination of both. If I understand the modeling pretty well, you're trying to capture the known impact of reduced exacerbations on quality of life, progression of bronchiectasis, et cetera, from the correlation in studies, and a little bit the decrease in FEV1. I think one thing about this agent that is going to make, and this class of agents that will make a big difference, is whether beyond their impact on exacerbations, whether they actually have an impact on disease progression over time. And I'm guessing that beyond their role on exacerbations or some extrapolation of the small change in FEV1 from this trial, you didn't try to model what if it has an independent effect on progression of disease. But correct me if I'm wrong.
There were another scenario analysis that was not presented here. So what if the patient experienced the accelerated rate of the exacerbation, which is kind of the corresponding to your question about the progression of the NCFP, and we could see the moderate changes in the incremental cost effectiveness ratio or the quality adjusted life years or the equal value life years gain. So we try to capture as much as possible, bearing with the lack of the data, but what we are able to capture is the moderate level.
Thanks, Dr. Kim. Jeff, a quick comment, question? Mute.
I think Dr. Diefenbacher maybe largely asked my question, but the real issue is it sounds like the biggest differentiator that would make this potentially more cost effective is effect on progression of lung function. And it sounds like that's kind of a big unknown at this point. Is that sort of a good summary?
Yep. So progression of the lung function, is this independent from the exacerbation rate? Or how much correlation that we have to give in terms of the progression and the exacerbation event? That's a kind of the area that we are looking for additional data from the phase 4 clinical trial or the real world study.
Great comment, great question. Tony, wrap it up for us.
Yeah, my question is perhaps for ICER as much as it is for Dr. Kim. I'm curious, was the manufacturer invited to participate in this session today? And related to that, assuming they weren't, or so they were, do we have any understanding of how they came up with the price of $88,000?
Dan, do you want to take this on?
I will absolutely take that on. They were invited to participate in our review at several junctures, including participation in this meeting and on our roundtable, and including a special personal outreach from Sarah. And they have declined participation in the meeting, but also other than public comment on our draft report, did not really engage in other opportunities. We always send a data request to manufacturers. We have a facility for them to submit confidential data to us if they want, but they did not participate in that. And we also offered a scoping conversation early on in the review. They did send some thoughts via email, but did not agree to have a call with us. So unfortunately, they were not engaged in the review as much as we would have liked.
Adding to that, throughout the model transparency program, they were able to see how we build a model and how the calculation was running on this model. That's a part of our collaboration with the manufacturer.
Thanks, Dr. Kim. Thanks, Dan. I think we're going to move